So I'll be talking to you about the imaging in surgical macular diseases. As we all know, as most of us ophthalmologists might have experienced, that we see a large number of patients in our day-to-day practice with macular pathologies, and most of these conditions are situations like CSR, AMD, then macular PRV or diabetic macular edema, and such conditions which can be managed either with the help of injections or laser. But there are certain situations which cannot be treated medically, which requires intervention through surgical means, and these are some of the situations like vitreomacular traction, macular hole, epiretinal membrane, and rare conditions like myopic tractional maculopathy and optic disc pit with macular detachment. So what are the investigations that we do for macular diseases? The fluorescein angiogram and OCT and fundus autofluorescence are the currently available investigative modalities for imaging and for investigating these macular diseases. Of this, I would say that fluorescein angiography is an invasive procedure. It is mainly useful for imaging of vascular retinopathies, but it can also be used in diagnosis of macular hole where you are having a doubt about the diagnosis. Because when you do a fluorescein angiogram in a patient with macular hole, because of the retinal defect, you will be able to see the underlying choroidal fluorescence. It somewhat resembles a window defect. There is no increase in size, there is no leakage, and it fades towards the late phase of the angiogram. So what is coming up now is use of fundus autofluorescence. This is not an invasive procedure. It makes use of the lipofuscin distribution in the retinal pigment epithelial cells. So in normal fundus autofluorescence in a retina, the retina has got a background diffuse fundus autofluorescence and corresponding, and in the macular area there is a relative hypoautofluorescence, and this is because of the pigments in the macula. So normally the macula is hypoautofluorescence, but when the patient develops a macular hole, there is no retinal tissue, there is no pigment to block the exciting light from reaching the retinal pigment epithelium. So you will be seeing the floor of the macular area as a hyperfluorescent area. And can I have the pointer? And surrounding that surrounding that hyperfluorescent area, hyperautofluorescent area, you can see an area of ring of hypoautofluorescence. This represents the subretinal fluid, and there is another zone that is external to the ring of hypoautofluorescence, which is relatively hypoautofluorescent, and that represents the area of retinal edema. And if you look carefully, you can see some radiating striae there. From in this zone of hypoautofluorescence, these represent the cystoid changes that have happened in the outer plexiform layer, and the presence of this radiating striae in the zone of hypoautofluorescence represent a smaller hole, or most probably a hole of recent onset. So this is also one way you can demonstrate to the patient that you have dealt with the macular hole surgically in a successful manner, because the hypoautofluorescence that was there before the surgery, it disappears after the surgery. Now OCT is one of the important investigation for evaluation of any macular pathology. In fact, it has made a paradigm shift in the management of most of the macular pathologies, so which especially requiring surgical intervention. So I would like to take you towards a normal OCT of the macula. So what you should understand is that it can help you to understand all the layers of the retina, starting from the retinal pigment epithelium up to the internal limiting membrane. But you should also be able to identify some of the important lines that you see on the OCT. So the first line that you see at the bottom, that is the retinal pigment epithelium. And there is another hyperreflective line just above this. It is called the cos line or the cone outer segment tip line. It is now called as interdigitation zone. It corresponds to the junction between the apex of the retinal pigment epithelial cells and the cone tip. And then just above that is the another line, that is the ISOS junction, which is also known as the ellipsoid zone. It actually represents the ellipsoid layer of the inner segment of photoreceptors, and it represents the presence of mitochondria. And another important line that is lying anteriorly, which is not as hyperreflective as the ISOS or the ellipsoid zone, that is the external limiting membrane. It represents the junction between the outer and the inner segment, or the cell bodies and the outer segment of the photoreceptors. It also comprises the junctional complexes between the photoreceptors and the Muller cells. So what is important is that in most of these macular pathologies which require surgical intervention, what you see is a disruption of these lines, and the first line to disappear is the cos line or the interdigitation zone, which is followed by the disruption of the IS-OS junction, and this is followed by the disruption of the external limiting membrane. But once the patient undergoes surgery and once the problem is properly corrected, the recovery happens in the reverse fashion. So the external limiting membrane appears first, it is followed by the IS-OS junction, and then followed by the cos junction. So what most of the pathologies that we are going to talk about now are in fact vitreomacular interface disorders. So we know that PVD is something which usually starts in the perifoveal area. At the same time, we can have the retina getting separated, the vitreous getting separated from the retina in the other areas, and ultimately it culminates in the process of the vitreous getting detached from the disc and the fovea, and this is when you call that the complete PVD has happened, and this is the stage when you examine, you will be able to see the Weiss ring. But sometimes this PVD does not happen the way it is designed to happen, and that is called the anomalous PVD. So you can have the vitreous still attached to the macula, and this vitreous can pull on the macula and can lead to tractional deformation of the macula. So one such stage is the vitreomacular adhesion. So vitreomacular adhesion is where you can see that the vitreous is attached to the macular area in an area which is roughly having a radius of 3 millimeters, and an important feature is that the patients are not symptomatic in the stage of vitreomacular adhesion. This stage, on OCT, what you will see is that the foveal contour is normal. You can see that the vitreous is detached all around the fovea, all around the 3 millimeter area, but it is not detached from the foveal, from the macular area, from the 3 millimeter area. So basically you can classify this vitreomacular adhesion into two types. One is a focal and the second is a broad vitreomacular adhesion. A focal vitreomacular adhesion is where the attachment is confined to the 1500 micrometers, and this is the area of the strongest adhesion between the vitreous and the fovea. Now, if the traction persists, or if the detachment does not happen, or the PVD does not happen, what happens is the vitreous keeps on pulling on the retina, and this is known as a vitreomacular traction. And when there is a vitreomacular traction, what happens is that the foveal contour is lost. The fovea gets pulled up, and you can have sometimes cystoid spaces in the retina. And another thing is that the photoreceptors, they start getting detached from the retinal pigment epithelium. And also you may be seeing some of the sciatic cavities in this area that is pulled up by the vitreous. So what you should understand is that there is no full thickness retinal defect at this stage. Now from the stage of vitreomacular traction, the eye can progress into the stage of full thickness macular hole. And one thing that you should understand is that you should not make a diagnosis of a vitreomacular traction just by looking at one scan. So you should take concurrent scans, the adjacent scans or the raster scans, and then look at all the scans individually, and you should look for a full thickness retinal defect, because some of these very small holes you will not be able to see it on all the scans. And OCT also helps us to measure the size of the macular hole, and what you take into consideration is the minimum hole diameter. It is the line that is between the most convex portions of the edges of the macular hole, which is drawn parallel to the retinal pigment epithelium. And based on the size of this hole, we can classify it into mainly three types. One is small, where the size is less than 250 micrometers, medium, where it is between 250 to 400 micrometers, and large full thickness macular holes more than 400 micrometers. So what you should understand is that the small and medium full thickness macular holes have got a very good surgical result. They are more likely to close with our surgical maneuvers. And the small full thickness macular holes, some of these very small holes can even close spontaneously without any surgical intervention. The large full thickness macular holes, they may require sometimes adhesion procedures like an inverted flap technique, or the technique that Dr. Meena was describing in his talk before lunch. Then OCT also helps us to identify the presence of vitreomacular traction. Why it is important to identify vitreomacular traction in a patient with vitreomacular hole is that we know there are certain agents that are now available for pharmacological vitreolysis. So agents like ocriplasmin jetria, which is commonly the name by which it is commonly known, it is used for pharmacological vitreolysis, and it's mainly employed only in those cases which are having a persistent vitreomacular traction. If there is no vitreomacular traction on OCT, then there is no point in using these medicines. Now, this is something that you can confuse with a true macular hole. A lamellar hole on clinical examination may look like a macular hole. So when you do OCT, what you find is that there is a disruption of the retinal architecture. There is a cyst which might have broken and which is spread laterally, mainly at the junction of the outer nuclear and the outer plexiform layer. And the important thing is that the photoreceptor layer is not affected, and so the most of this patient may be having good visual acuity in spite of the hole on OCT, and most of these patients do not require a surgical intervention unless there is a decrease in vision. And some of these lamellar macular holes in course of time can also develop into a full thickness macular hole. A pseudohole is where you have an epiretinal membrane with a defect at the center. It looks like a macular hole, and then on OCT what you see is that there is a thick epiretinal membrane on the surface of the retina, and this epiretinal membrane is pulling the retina towards the center, so you can have a heaped up or invaginated edges of the fovea, and this is another situation where you don't have to do any surgery. You can see that the central retinal thickness is maintained, all photoreceptor layers and everything is intact. So once you do surgery, then again this is important because some of the patients may not benefit much from the surgery. So you have to do an OCT, and you may have to show the patient that, see, I have done a good job, that thing is the vision has not improved, maybe because of some other cause. So there are mainly two types of closure of macular hole. One is a type 1 closure and the second is a type 2 closure. Type 1 closure is where the retina closes without any disruption in between. So you have got the retinal tissue as well as the gliotic tissue filling the gap where we were having a macular hole before the surgery. Now, type 2 closure is where the elevated edges of the retina is flat. That is, it is attached to the retinal pigment epithelium, but there is a disruption between the two sides of the retina. So, in OCT also gives us enough and ample support, ample evidence to support the visual acuity that the patient has gained. Because here again you look at the ELM, there's external limiting membrane, ISOS junction, and the cos lines. And if the external limiting membrane has appeared, then that means that the patient is going to or may have a recovery of the ISOS junction in the future. So once the extent to which these lines regenerate can to some extent explain the visual recovery in these patients. So there are many macular hole parameters and various studies have shown that different parameters can be used to predict the surgical outcome as well as the visual outcome in these patients. Now, epiretinal memory formation, this is also due to an anomalous PVD. When there is a PVD, sometimes the vitreous does not get separated completely. There can be a vitreoskisis, there can be a small layer of vitreous on the retinal surface on which the glial cells and laminocytes can contribute to the formation of an epiretinal membrane. And here again you can do a fluorescein angiogram. I don't think it's going to give any extra information unless you're suspecting something like an underlying CNVM. What you see in a fluorescein angiogram is the tortuosity of the vessels. Sometimes you'll be able to appreciate the leakage from these vessels also. And again here the most important investigation is OCT. You can see this hyperreflective line over the retina which represents the epiretinal membrane, and you can also see the macular edema. Here again you should look at the ELM and ISOS junction, and if those lines are not very well defined, then the patient could be having a very poor vision at that time of presentation. An important thing is that you should, if the patient is having ERM, all the patients do not require surgery. If the vision is good, you don't interfere in these patients. You keep on following up the patients with repeated OCTs, and you may be able to demonstrate an increase in the thickening of the macula over a period of time. And if this is associated with a decrease in vision, then that is an indication for surgery. Now, optic disc split with maculopathy. This is a differential diagnosis for CSR. Whenever you see a patient with CSR, look at the optic disc, look for an optic disc split. See, there are many theories about where the fluid in the subretinal space is coming from. Some people say it is from the subarachnoid space. Some people say that it is from the vitreous. So, one of the most favored theory is that the fluid has come from the vitreous. And what is the reason that is given is that there is again vitreomacular interface interaction, or there is a traction on the macula which is causing a negative pressure in the subretinal space, and due to this negative pressure the fluid from the vitreous gets drawn into the subretinal space through the optic disc split. So there are studies which say that if you do just a good posterior vitreous detachment in these patients, there is a chance that this detachment can recover without any other extra procedures like a laser along the optic disc split margin or ILM peeling. Now, this is another condition which is being recently detected mostly with the help of OCT. So, in myopic patients, especially those patients who are having high myopia with posterior staphyloma, sometimes the patient can present with sudden decrease in vision. So, one cause or the most common cause that we think about in such a patient is the presence of a CNVM. But in addition to CNVM, the another cause that could explain the decrease in vision in a myopic patient, especially a high myopic patient, is a myopic traction maculopathy. Here you can see, you may be able to see an epidermal membrane or a vitreous that is pulling on the macula, and some of these patients can have schisis of the retina in the macular area, which may give rise to a lamellar hole and sometimes to a full thickness macular hole. And sometimes these patients can have a detachment that is confined to the macula without any macular hole formation. So, in a nutshell, almost all the investigative modalities, especially OCT, is very important in diagnosis of most of the macular diseases in the surgical, which require surgical intervention. It helps us to prognosticate the results in some of these patients, and it's also an important tool to explain the results of the surgery to the patient. Thank you.